So good morning everybody. This is Dr. Gitanjali Sharma, moderator for the session, and chairman for today's session is Dr. Garuk sir. May I request sir to say a few words as opening comments?
I welcome you all, my colleagues on dais, all the speakers and audience. Our first paper is keynote address by well-known doctor from RP Center, who has won the award in the community ophthalmology last year. His paper is Nation Survey for Mapping Human Resources and Infrastructure from Eye Care Services in India. Dr. Parveen Vishist, please.
Thank you, sir. In fact, last year I presented this paper in Community of Ophthalmic session and got the first award. This is about the National Survey on Human Resource and Infrastructure for Eye Care Services in India. And this survey was conducted jointly by RP Center, National Program for Control of Blindness, Vision 2020 Right to Sight India. I also represented the Vice President of Vision 2020, and it was funded and sponsored by Orbis India. In fact, when we started Vision 2020 Right to Sight program in India in 2004, at time we had a target of human resource and infrastructure by the year 2020. For human resource, we had a target that we should have 25,000 ophthalmologists and 48,000 paramedical ophthalmic assistant in country by the year 2020. And as far as infrastructure is concerned, we targeted that we should have at least 2,000 secondary level hospitals and around 200 tertiary level hospital in country. And this survey was conducted to actually assess whether what we have achieved by the year 2020 in the country. So objective was to obtain an estimate of the number of eye care institutes, services, along with the number of ophthalmologists, ophthalmic paramedics in India, and also to link this database to India Vision Atlas, which was developed by RP Center and in which we included National Blindness Survey and National Diabetic Retinopathy Survey. In fact, the methodology was we prepared the list of eye care institute. There was no list available actually. We used all the resources, Google, Ministry, the various NIC district panels, everything was included. And that was a peak COVID time. Our team were available. So telephonically we contacted all the available hospital in the country. You can understand it is a difficult task actually. We targeted only secondary and tertiary level hospital because for primary we are not very sure it actually functioning or not. So the condition was that there should be at least one ophthalmologist working there, whether full-time or part-time. That was the initial criteria. So 30 staff members, they were given 1 or 2 state each person, and they telephonically contacted all the institutes. In fact, this data was collected online through online questionnaire. We use monkey-based software and virtual meeting. And besides contacting all the institutes, we also use Government of India support, where the national level coordinator, we had meeting with all the state program officers one by one, including their district program manager, so that we can get complete data from each district. And in fact, it was again validated. Whenever we get questions, we resend the question to all the institutes so that they can validate this information is right and it is just not written like this. So these are the results. We could get information about 9,440 institutes, I mean to say their email address and mobile numbers. We were able to contact 8,790 institutes. Out of them, 7,901, they actually submitted their data, which is 89.9% total. And we get special information about institutes providing pediatric eye care facilities. So 27.6%, 2,180, they said they are providing pediatric eye care services. Then we use various indicators to judge this data. This Eye Institute population ratio. These are recommended by Vision 2020 as well as NPCB. Ophthalmologist population ratio, optometrist or ophthalmic assistant institute ratio, and this was calculated for the overall country, for each state and every district also. We have nearly 7,039 districts in country. For each district we calculated this information. And the best part was that WHO requested us to form eye care situation analysis data, and we use this information for providing this information to WHO, and India was the first country to provide such information to WHO based on this data. We can also develop more indicators as per the need, like pediatric eye institute population ratio, like pediatric ophthalmologist population ratio, and so on. So this is the like indicators developed. We have shown India level indicators, and they can be developed for state and district level also. For example, we had one institute per 1,64,000 population in India, total 7,901 institute. As far as ophthalmologists are concerned, I said we had a target of 25,000. We got information about 20,944 ophthalmologists in country, one ophthalmology per 65,000 population country. As far as optometrists are concerned, we got information about 17,856 optometrists. One optometrist in one institute, there are 2.26 optometrists in an average. As well as pediatric institute is concerned, total 2,180 institutes are providing information about, they have pediatric ophthalmic services, one per every 6,30,000 population. And pediatric ophthalmology population ratio, it was 8 per 10 million population. This is information ownership. As you can see, the maximum number institutes are in private sector, 70%, in government sector 15.6%, and in NGO sector it is 13.8%. Type of eye services, operation theatre, 87% institute, they have OT facilities. Eye bank is there in 5.7%. Low vision services are provided by 28.3% institute. And various subspecialties, cataract is the leading one, with nearly 91.5% institute they provide cataract surgical facilities. The second component was linking this database with India Vision Atlas, probably very important component, because the report are there in pages, nobody sees that. If we can link with online India Vision Atlas, that can be useful. It is visible to everyone, and anyone can see this information sitting at home also. So we conducted national blindness survey, and India Vision Atlas was prepared with the support of Government of India by RP Center, and we had the data related to entire country data, state level data, survey data, and we added this component of HR infrastructure in this India Vision Atlas. And in fact, you can see all the indicators in this Vision Atlas, and they are available state-wise and district-wise. All these indicators are available. You can categorize these indicators, you can check for state, you can check for district level information also by clicking on the state data. And we can also check eye care institute details in the Vision Atlas. For example, when we click this data on eye care institute, we get information about those institutes. We can further filter them based on the state, based on districts, based on ownership, whether it's government, private or NGO sector, based on facilities available and services available. So all these information can be assessed using this India Vision Atlas. For example, for Kerala, we say it is one of the district LPJ and glaucoma facilities in Kerala. So we can get this kind of information in the Vision Atlas, where you have the name of the institutes available in that districts, and also various services, whether available or not available. So how good it is that even whether it is program planner, policy makers, or even the patients, they can see which institute is available and what services are available nearest to that person. We are able to provide this kind of information to the patient people in our country. And this is also linked with Google Map. So one can also see the distance of that specific institute from them. So this is something very positive. They need to go to that place, they can even go to that place. So it is actually bridging the accessibility issues in our country, where people feel that services are not available. They can actually see whether services are available in their area or they are not available. And it can be updated periodically. We are planning that every 2 years we'll get the similar data from all institutes, so that we can update this information for the country in a regular process. To summarize, where we have adequate number of eye care institute. In fact, target was having to have 2,000 institute, and we have much higher, 7,900 institute providing secondary or tertiary or higher level services. But 70% of institutes are in private sectors, and usually private people, they are not submitting data to national program. It is essential that there should be a public private partnership. Those institutes be part of it. The reported number of ophthalmologists are 20,944, quite close to 25,000. Optometrists are much less, 17,856 against target of 48,000. Vision Atlas is helpful for planning also, and also for the people who need to assess about the services. And this was the survey, and I'm really thankful to all the team members, Government of India, they were our partners, AIOS, Dr. Namita Sharma, Dr. Rohit Saxena, Dr. Rajesh Sinha, Vision 2020 Right to Sight, Orbis. So that was a great effort by the entire team. Thank you very much. Thank you.
Thank you, Dr. Vashisht. It was an excellent paper and the prize-winning paper for last year's AIOS. And you all must have noticed that it was all inclusive. That was too good, using technology and reaching to the community and taking the data. Excellent, sir, and congratulations.
Do you have offline and online copies of this?
Of this
Data.
Hard copies are there
this
in
paper,
your
sir.
institute?
Sir, all online copies are there, hard copy
Online.
or not on.
Not.
So anyone can go to the Vision address, India Vision address, and see this entire.
Okay. Very well. Thank you.
And it was the best use of the COVID times, I guess. So let's move to the first speaker for today's session. Ocular manifestations of COVID-19 vaccination in a tertiary care hospital in India. So this is Dr. Payal Mukherjee presenting. So first.
Good morning, everyone. The topic of my paper is Ocular Manifestations of COVID-19 Vaccination in a Tertiary Care Hospital in India. How to move the slide? Please pause it. Timer. हाँ, तो timer को reset. Okay, good morning everyone. The topic of my paper is Ocular Manifestations of COVID-19 Vaccination in a Tertiary Care Hospital in India. I've got no financial interest for this study. COVID-19 is an infectious viral disease caused by severe acute respiratory syndrome coronavirus 2, that is SARS-CoV-2, that primarily affects respiratory system, but severe infection may affect multiple organ systems. Data from WHO says till December 2021, the pandemic has affected about 26 million patients in India and 300 million people worldwide. Since the outbreak of the pandemic, active research has been going on regarding vaccination to provide acquired immunity and prevent severe illness and deaths from the disease. The vaccination program in India started on 16th January 2021 in a phased manner, allowing high exposure groups first, then comorbid and elderly patients, and finally everyone above 18 years age. Initially, two vaccines, Covishield undergoing phase 4 trials and Covaxin undergoing phase 3 trials were approved for emergency use, and finally Sputnik V was also approved. In this study, we aimed to evaluate the various ocular manifestations in previously asymptomatic patients who visited IOPD of a tertiary care hospital in India after COVID-19 vaccination. This observational hospital-based study was performed in a IOPD of tertiary care hospital in India between January 2021 to July 2021. My inclusion criteria included vaccinated people taking first or second dose of Covishield or Covaxin in the age group of 18 to 60 years, previously asymptomatic cases, and those who gave consent for the study. The patients whom I excluded were those who had similar symptoms before vaccination, patients with media opacities, previously documented retinal diseases and uveitis, and those who lost to follow-up or did not give consent for the study. Ethical approval was taken and whole study was undertaken according to Declaration of Helsinki. All participants provided informed consent before being included in the study. Detailed history was taken, detailed ocular examination were done, and all findings were noted down. All patients were called for follow-up after 1 month and 3 months. Data was tabulated and analyzed. These are my results. Total 57 eyes of 31 patients with ocular symptoms after COVID-19 vaccination were evaluated. All the patients belong to age group of 18 to 60 years. This is a table showing age-wise distribution of patients, in which maximum patients were of age group 20 to 30 years. In our study, we enrolled 31 patients, of which 23 were males and 8 were females, giving a male-female ratio of 2.87:1. 12 patients were administered Covishield and 19 patients were administered Covaxin. Of the total patients, 27 patients presented to IOPD with ocular symptoms after first dose of vaccine, and 4 patients who were asymptomatic after first dose presented to IOPD after second dose of vaccine. 26 patients presented with bilateral ocular symptoms and 5 patients had unilateral ocular symptoms. Now, this is a table showing ocular manifestations of the COVID-19 vaccination, which I found out. Ocular manifestation after COVID-19 vaccination were broadly categorized into 4 groups. Group A had maximum number of patients with allergic symptoms. Group B had patients with reactivation of the latent herpes zoster infection, that is herpes zoster ophthalmicus. Group C had first attack of acute anterior uveitis, and Group D had central serous chorioretinopathy. Allergic reactions to COVID-19 vaccine may be due to adjuvants or other components in the vaccine such as preservatives, antibiotics, etc. Adjuvants potentiate vaccine-mediated immune responses and stimulate innate immunity through cytoplasmic toll-like receptors. It is assumed that development of ocular phenomena post-COVID-19 vaccination may occur via immune response elicited by the vaccine. Also, these similar reported conditions appear to be common to ocular manifestations reported in patients who were infected with COVID-19. This suggests a common pathway between virus and vaccine-mediated immune response in humans, possibility a toll-like receptor. Now coming to vaccine-associated uveitis, it has been reported with almost all viral vaccines. Molecular mimicry between vaccine peptide fragments and uveal tissue cell peptides and delayed hypersensitivity leading to deposition of immune complexes in the tissues have been suggested as a possible reason for vaccine-associated uveitis. The association between reactivation of latent herpes zoster infection and COVID-19 has been previously reported by many authors, the most probable reason being lymphopenia, decreased CD4:8 cell ratio, and vaccine-induced immunomodulation. In our study, the patient who was vaccinated with Covaxin who developed CSCR 4 days after administration of second dose is perhaps the first reported case of CSCR as an intraocular side effect associated with Covaxin. In literature, only one case of CSCR has been reported till date in a 33-year-old male, 69 hours of administration of Pfizer-BioNTech. Currently, not much literature is available regarding COVID-19 vaccine-induced CSCR pathogenesis course and outcome. It is postulated that in Covaxin, the modified viral RNA, although is incapable of replication, but has some role to play in increased permeability of endothelial cells, leading to leaky choriocapillaries. Several other adverse ocular manifestations has been reported in literature, like panuveitis, choroiditis, scleritis, etc., which were not recorded by me in my time period. Our study had several lacunae. The duration of study was short and many patients didn't report to IOPD or lost to follow-up. Also, patients were included from only one tertiary care center in a limited time period. Also, history and antibody titers of COVID-positive patients were missed out. Thus, to conclude, COVID-19 vaccination is currently under clinical trials and not much information regarding their safety profile is available. So, vaccine-related ocular manifestation should be taken into consideration and serious side effects should be reported. These are my references. Thank you.
These complications or whatever ocular manifestations you saw in these patients, did they have any comorbidities?
No, ma'am.
Did you
Yes, ma'am,
have you taken a note of them?
Yes, ma'am. I took detailed history and I excluded all those patients.
Okay, thank you.
You got 57 patients out of total how many?
31 patients, 57 eyes.
57 eyes, but how many patients were actually examined? What proportion of patients had this kind of disease? What was the total N?
Yes, so
Total
that
number of
incidence.
examined, it is not there with you. You said loss to follow-up. Is it a cross-sectional study or it's a cohort study?
Observation.
It is observation
Yes, sir.
cross-sectional
Yes,
study.
sir.
So how can you say loss to follow-up in a cross-sectional study? That is usually in cohort study, loss to follow-up.
So some patients who presented first time they didn't had symptom, we called them if they had any manifestation or in 3 months, but they didn't turn up.
So actually why are you examined twice? What is the reason? In first examination and second examination after 3 months, what is the reason for that?
So because we wanted to take a detailed survey if there is some delayed manifestation of the vaccine-induced side effect. Maybe in 1 week many people didn't turn up, then at one month maybe somebody came with red eye and then I called after follow-up, they didn't come.
Can you exactly tell me what changes were seen after 3 months in any patient if you saw, like observe?
So like those patients which we treated, many patients like CSCR patient that resolved. They recovered.
So one more question, you said the maximum number of this people affected were 20 to 30 age group.
Yes, sir.
Is there any specific reason for that? Why not old population affected? Why young population
Sir,
is more
because
affected?
older population didn't come to us after vaccination. The
But
young.
when you say distribution 20 to 30, it seems as if the younger population is more affected with
Yes, sir.
symptoms.
Sir, it also depends upon which population group presented to hospital.
Okay.
Sure.
Okay. Thank you, ma'am.
Thank you.
Nice presentation.
Thank you.
Thank you. Our next presentation by Dr. Piyush Kohli, incidence of ocular and systemic disease affecting visual function among state bus drivers.
Good morning, everyone. I'll be presenting prevalence of ocular and systemic diseases affecting the visual function among the state drivers. It is prevalence. How to move it? Okay, so let us understand the magnitude of the problem. So road traffic injuries form one of the leading causes of death. In 2017, it was ranked 11. In fact, by 2030, it is estimated to become the 5th leading cause of death. The greatest burden is in low and middle income countries. So what is the magnitude of problem in India? Although a large number of road traffic accidents go unreported, it is reported that 1230 accidents, 414 deaths and 1237 injuries occur per day, out of which 84% are among the working age groups. According to World Bank, 10% of Indian hospital capacity is always filled with crash victims. The social economic loss that leads to is 3 to 5% of the GDP every year. So what is the role of buses in Indian transport? Nearly 1.7 lakh buses and 5 crore people ply daily on Indian roads. 85% passengers and 65% freight travel by road. So in 2019, buses led to 4.9% of the road traffic accident related deaths. So what is the problem with Indian roads? Roads lack segregation for motorized and non-motorized traffic. And the heavyweight vehicle drivers need to be overcautious to prevent the road traffic accidents. So what is the need for this study? There are several lacunas in the laws related to driving licensing in India. First is the visual requirement is based only on the visual acuity, whereas the other functions are ignored. The ocular and systemic disorders, which can hamper the driving proficiency, are also ignored. So evaluation of incidence of these diseases among the current driving license holders will help us establish the baseline epidemiological data for the high-risk drivers, as well as establish better road safety laws. So aim of the study was to evaluate prevalence of the ocular and systemic diseases affecting the visual function among state transport corporation drivers in South Indian district. So this was a retrospective observational cross-sectional hospital-based study performed at Arvind Eye Hospital, Madurai. The records of all the drivers who came for mandatory annual checkup in 2019 were evaluated. So the rules of the State Transport Corporation were that mandatory annual ocular examination was needed, and fitness for criteria was BCVA should be at least 20 by 20 in the better eye and at least 20 by 40 in the worse eye. And there should be no defects in the color vision, in the visual axis, in the night vision, in the visual field, and the binocular single vision. So all the tests that are usually performed, and in case of any pathology, appropriate systemic and ocular investigations were done and the patients were treated. So we evaluated a total of 3042 drivers with a mean age of 47 plus minus 5.7 years with a range of 29 to 61 years. So visual function threatening systemic disorders were seen in 761 drivers, that is 25% of drivers. And in fact, 2 were diagnosed to have hypertension based only on the ocular examination. So among these 761 drivers, 63% had diabetes, 30 had hypertension, 5 had ischemic heart disease, 2% had others which included tuberculosis, HIV, chronic kidney disease, neurological disorders and blood dyscrasias. So refractive errors were found in at least 45% of the patients, 460 were myopic and 917 were hypermetropic. A spherical equivalent of more than 1 diopter was seen in 8.8% of the drivers. Visual function threatening ocular disease was seen in 9.5% of the drivers, out of which only 1.5% complained of visual loss. Other had just come for the regular examination. So these diseases include DR in 42% of the patients, which included PDR, non-proliferative diabetic retinopathy, the central involving DME, macular ischemia. In fact, the incidence of diabetic retinopathy among drivers with diabetes mellitus was 21.3%. The other disorders were cataract, glaucoma, out of which majority had primary open angle closure glaucoma, but a majority had primary angle closure also, CSCR and others. Others were RVOs, pterygium, retinal hole, toxic optic neuropathy, etc. So visual significant cataract was seen in 1.9% of the drivers, out of which 15 had bilateral and 2 had traumatic. 2.2% underwent surgical intervention, out of which 41 had cataract surgeries. 13 drivers were undeemed for fitness. So UN has announced 2011 to 20 as decade of action on road safety. Reducing the number of road traffic accidents is related deaths is among the UN Sustainable Developmental Disorders. The government of India is committed to reduce the road traffic accidents and death by 50%. So why is diabetes a risk factor? It's not only because of the visual function, but also because sudden hypoglycemic episodes while driving can lead to cognitive impairment and psychological retardation. Also, peripheral neuropathy can impair the sensation and proprioception in the lower limb, which can affect their ability to gauge pressure on acceleration, brake and clutch pedals. Then diabetes in our study, incidence was 20%. It is estimated that the incidence of these metabolic disorders in bus company employees is higher compared to the general population. That is because of the long working hours and the sedentary lifestyle. The incidence of diabetic retinopathy among the diabetic drivers was 20%, which is much higher than the Indian population, which is about 9.2%. Then 40% of the people suffering from glaucoma can experience driving difficulties. Incidence of glaucoma in our study was similar to the general population, but these drivers have to drive in the evening and they are at high risk of angle closure attack. So shallow angles may benefit from prophylactic laser. Without spectacles, nearly 50% drivers fail to qualify the visual acuity criteria, so the compliance to spectacles at work should be checked frequently. A number of patients had cataract, which can lead to glare during the evening drive, even though they have a good visual acuity, which can delay the response time delayed due to the headlight glare, which can increase the risk of collision. And CSCR also leads to metamorphopsia, which can impair the ability to judge distances. So an early laser can be done in these patients. To conclude, several bus drivers suffer from vision-threatening systemic and ocular diseases. Some may even require surgical intervention. We should evaluate the ocular and systemic diseases with vision-threatening potential at the time of license renewal. The driver should be educated about the systemic and ocular disorders that can affect driving skills, and they should be encouraged to seek the medical help at an early age. Importance of treatment compliance should be emphasized to these patients. Thank you.
What about the color vision testing? Did you do?
Yes,
for
no,
all?
color vision test was done.
Sir, can I ask one
Yes,
question?
sir.
It's a retrospective study on a hospital-based data.
Hospital-based data.
Still, you are giving information about incidence. You are giving information
Prevalence.
prevalence. In retrospective data, incidence can be assessed only. How you assess the patient coming to hospital?
Yes, sir.
Then how do you know about incidence?
No, so this was prevalence, not incidence. I'm sorry.
It is not even prevalence. Prevalence is definitely by cross-sectional study.
Yes, sir.
It is just a proportion of patient coming to hospital. It is not incidence or prevalence at all.
Okay.
And everywhere you have mentioned these two things in this.
Yes.
This is totally actually not acceptable.
Okay.
It is just proportion of patient having these disease.
Yes, sir.
And having prevalence of diabetes so high among truck drivers, and it automatically shows it is not incidence or prevalence.
Okay.
It has to be proportion only.
Okay.
Right?
Yes. Thank you.
Thank you, doctor. Our next present is a comprehensive study on health and fitness among ophthalmologists in India. Dr. Janu Samsod.
Sir, please. एक मिनट,
एक chair लगेगा.
एक chair room में.
Good morning, everyone. Today my paper is on a comprehensive study on health and fitness among ophthalmologists in India.
Actually, they have to put
एक minute, हाँ? One more sheet. Just a moment.
एक sheet और लानी है. एक co-chair है.
She is there. He is
Ma'am,
there.
एक
अब इनका टाइम
एक चेयर यहाँ पे रखवा दीजिए मैम. एक चेयर यहाँ पे रखवा सर, यहाँ पे. You can restart the time.
Good morning, everyone. Today my paper is on a comprehensive study on health and fitness among ophthalmologists in India. So this work studies various factors related to health and fitness among ophthalmologists in India. It's a comprehensive questionnaire was created in Google form and distributed to ophthalmologists across country through various social media platforms during the time period between March 1 and May 1 of 2021. The questionnaire has addressed the various areas of work pattern, food consumption pattern, career satisfaction, fitness activity, occupational health hazards, and impact of COVID-19. So this survey is being taken up by 537 ophthalmologists across the country, out of which 76.91% were females. More than half of the respondents were working at government hospitals. As you can see from the graph, around 50% of the respondents were residents, 41% were consultants, and rest were fellows. While coming to the work pattern, 21.34% of respondents reported that they do not get at least one off day per week. 12% even reported that they have to work for more than 10 hours per day on a consistent basis. So comparing this with the statistics of developed countries, wherein the working hours of doctors are less than 48 hours per week, we can see that Indian ophthalmologists are putting forward much more working hours. Working for longer hours on a consistent basis is associated with increased risk of hypertension, cardiovascular disease, and mental health disorders. 13% of the respondents reported that they do not get at least 6 hours of good night's sleep. This is again associated with a high chance of hypertension. While coming to the food consumption pattern, 44.13% of ophthalmologists regularly skip their meals due to work schedule. This is again associated with poor diet quality, increased risk of central adiposity, and insulin resistance. Despite this trend, it is promising to note that majority of ophthalmologists are trying to inculcate healthy dietary patterns. While coming to the fitness activity pattern, only less than half of ophthalmologists are having the habit of exercising regularly, and the most popular exercise activity is walking. Men were found to be more health conscious than women, and it is supported by the fact that male ophthalmologists are investing more time on fitness compared to females, consultant more than residents. A previous study conducted by Moore et al. Performed in general population found that youngsters spend more time on exercise. However, we are having contrary results, maybe because of the higher working hours that resident has to put forward. Females tend to spend lesser time on fitness activity due to the disproportionate domestic and parental responsibilities, especially in a country like India. Majority of the respondents find it difficult to allow time for fitness, mostly because of an inflexible workplace, work pressure, or simply because of lack of motivation. Discussing about occupational health hazard, a significant number, that is 57.16% of ophthalmologists are suffering from occupation-related neck and back pain, out of which 44% has resort to analgesics to relieve themselves from the pain. Females were found to be more suffering from occupation-related neck and back pain compared to males. All these findings were consistent with previous studies wherein it was found that prevalence of neck and back pain among ophthalmologists to be between 50 to 70%. We couldn't find any statistically significant difference between consultant and residents in this regard. This is contrary to the finding by Ramesh Venkatesh et al. That younger ophthalmologists are suffering from neck and back pain more than seniors, as they cater to more patients, work longer hours in OPD, and spend more time during procedures. It is saddening to note that almost everyone has gone through psychosocial stress or verbal abuse during their course of career. More than half of the respondents has contracted disease from the patients, the most common being COVID-19 and conjunctivitis. The list even include highly lethal diseases like tuberculosis. On the brighter side, 57.9% of respondents agree that the current COVID scenario made them invest more time on fitness. More than half of the respondents were satisfied with the protective gears provided by their institution with good confidence. Around 2/3 of the consultants has suffered from a pay cut during COVID-19. Despite of all this, it is quite promising to note that 64.04% of ophthalmologists are content with their career with good confidence. This is again comparable with similar studies conducted in Canada and Nigeria, and we couldn't find any gender bias when it comes to career satisfaction. Our study is limited by factors like inherent sampling error of any survey. Due to the open nature of the study, it may have caused non-response bias. Parameters like obesity and addiction are not assessed in the study. Despite of all this, we believe that the findings in the study can be utilized by the fraternity as well as the policymakers to enhance the quality of life of ophthalmologists. To conclude, majority of ophthalmologists suffer from occupational health hazard. Even though there is a strong desire to spend time on fitness activity, the majority find it difficult. COVID-19 hurt ophthalmologists due to salary cut and contraction of disease. Thank you.
Thank you. Good study, a good sample size, 557 of 37 ophthalmologists. Only thing is that probably it is more towards resident. 50% were residents, and I believe they are not from government sector, because in government sector there were no salary cut, but you were saying there's salary cut.
I was telling about only consultants, sir.
Only
consultants. 2/3 of consultants have suffered from salary cut.
okay. In government sector there was no salary cut.
But,
that may be
private
reason.
practice
Private
is
practitioner may be there. Definitely you must publish this paper. This is better, but it will be better if you also classify. You give male and female gender difference there, but young and consultant versus resident. And if you have something about their mental satisfaction, whether they satisfy the job, that questionnaire is there too.
64% of
So the specific questionnaire should be used, which is provided by a psychologist or something. That's better. Anything?
Any questions from the panel?
Thank you.
Thank you. Congratulations, nice paper. Yeah.
Should I?
Next is, Dr. Salil Kumar Mandal. Presenting author is Dr. Jeet Bunia. The paper is about assessment of prevalence and risk factors for COVID associated mucormycosis, an observational audit.
Good morning, everyone. My topic, assessment of prevalence and risk factors for COVID-associated mucormycosis and observational audit. No financial interest in the study. Too much of personal comments without any scientific evidence portrayed by media creates ambiguity and confusion. This study intends to provide an understanding about the risk factors associated with mucormycosis. Introduction. Mucormycosis is a rare opportunistic fungal infection. Rhino-orbitocerebral mucormycosis (ROCM) is the most common clinical presentation of mucormycosis. Mode of infection: inhalation of fungal spores. Common associations: diabetes mellitus, corticosteroid therapy, immunosuppression, asthma, and chronic obstructive pulmonary disease. Aims and objectives: to establish the associated risk factors in CAM, to estimate the prevalence of risk factors in CAM cases. Material and methods: several parameters were chosen for their presence and subjected to statistical analysis to assess their influence as risk factors. Parameters included COVID-19 affection confirmed by RT-PCR report, cyclic threshold value and computed tomography severity score, diabetes mellitus from history, FBS and PPBS at the time of presentation, hypertension history, past use of steroids from old treatment records, past use of tocilizumab during COVID-19 treatment, past use of remdesivir and oxygen during COVID-19 treatment, past use of prolonged zinc supplementation and prolonged regular steam inhalation, conditions of already prevalent immunosuppressions, socio-economic status of the patient assessed as per modified Kupuswamy scale. The time period was from 1st March to 30th August of 2021. 83 numbers of diagnosed cases of ROCM were included in the study. Diagnosis was confirmed by endoscopic biopsy. This is a picture of the histological slide. Presence of all these parameters were confirmed not only by history taking but from all treatment records. A control group of 83 patients, age and sex matched, without ROCM but having diabetes mellitus and some of the other risk factors were included in this comparative study. These are some pictures of the patients while I was conducting this study. A master data chart of the patient particulars and all parameters was prepared. Prevalence of the parameters was extracted from the data pool. Comparative analysis with control group was done. Statistical significance was analyzed. Risk factors identified in this way. Coming to results, we had compared the gender distribution and the mean age group between the cases and the control, and the p-value was not significant. Coming to stage-wise distribution of ROCM, most of them were in the stage 2, that is orbital involvement, where stage 1 is involvement of nasal mucosa and sinuses, and stage 3 being the cerebral involvement. These are some pictures of the MRIs of the patients. This is a bar diagram showing the prevalence of the parameters among the cases and the controls. To explain this, we got, except in case of hypertension, all the other parameters were showing an odds ratio of more than 1, which implies a positive correlation. We had compared the mean FBS and the PPBS between the cases and the controls, and it was statistically significant in both the cases. Coming to socio-economic status, most of the cases were lying from the lower to the upper lower socio-economic strata, which when compared with the control group provided a significant value, which was highly significant. Comparing the cyclic threshold value and the mean computed tomography severity score between the cases and the control yielded no significant value. Discussion: not much data are available about the rise of mucormycosis cases due to lack of evidence-based studies and the rarity of the disease. Prior history of the following were found to have positive correlation with the prevalence of ROCM, which are history of RT-PCR proven COVID-19 infection, poorer socio-economic status, history of steroid therapy, requirement of oxygen therapy, history of remdesivir and tocilizumab intake, poor glycemic control, prolonged period of steam inhalation, prolonged zinc supplementation. We had compared our findings with that of available literature and found agreement in cases of COVID-19 affection confirmed by RT-PCR report, diabetes mellitus, past use of steroid, past use of oxygen during the COVID-19 treatment. All these showed a positive correlation which was going in accordance with the previous studies. To conclude, further analysis with larger sample size is required to supplement the present study in order to validate these positive correlations as possible risk factors for CAM. In the present scenario, with increasing incidence of CAM being reported every day, the findings of the present study might aid in prevention and early detection of CAM among the susceptible populations. These are my references. Thank you.
Any questions from panel?
What is the role of supplementation? The role of zinc supplementation for prolonged period?
Zinc supplementation?
Yeah.
So, this is for the the zinc supplementation is used for the COVID-19 treatment, and it was found to be a risk factor for the mucormycosis. Like it was found to be a risk factor, and it was used for the patients, and they presented with mucormycosis. And the zinc supplementation, these patients were taking for more than around 3 months, like continuous zinc supplementation, even after the cessation of the COVID-19 disease treatment.
I don't know, not very much proved studies are there.
Yes, sir, it was the previous studies doesn't agree with that.
Yeah, thank you.
Okay. Did you find any correlation with dental problem and mucormycosis? Because we in our study, many patients had these dental issues who developed orbital mucormycosis.
I did find, but I found only in 2 patients. I didn't include that in the study.
That is surprising because we had to train our dental department for that, to detect the cases and send immediately to ENT and ophthalm department. Okay, thank you. Sir, your question?
It was fantastic, good study. You've seen most of the factors which are associated with it and good statistical analysis. Thank you.
Thank you. Next presenter. Presenting author is Dr. Atul Kamath. Chief author is Dr. Binita Gadavi. Yeah, it's a SEEPS test, a novel test to check wound integrity.
Good morning, everybody. I'll be presenting my paper on SEEPS test, a novel test to check for wound integrity. I have no financial interest. Introduction. There is always a concern for the surgeon that leaving incisions without a definitive closure may increase the risk of wound leaks and further increase the chances of infection. So the SEEPS test is a name given after the surgeon Stephen B. Seepser, who came out with this test. The SEEPS test can assure that a surgeon has a watertight wound along with sterilizing the ocular surface at the end of the surgical case. Especially among postgraduates, this can be a boon where this test acts as a river bank for the outflow of aqueous, outlining the speed, location and quantity of the leak. The procedure is simple and straightforward, can be easily performed and the findings are accurate. We use this procedure among all the residents training in ocular surgeries to detect any wound leak after performing the surgeries. So method, the study was undertaken in the ophthalm department of Guru Gobind Singh Government Hospital, Jamnagar in a 12-month duration span. Informed consent and approval from the local ethics committee was obtained. 150 patients who were undergoing ocular surgeries performed by postgraduates were included, and any patient irrespective of age, gender or history of any comorbidities were included in the study, and all cases were performed after giving a peribulbar block. At the end of the study case, the globe is inflated to a normal pressure and the globe is confirmed to be firm by using a finger tension ballotment at the end of the surgery, and then 2 or 3 drops of betadine 5% is instilled over the wound. If there is any leaking aqueous, it is outlined by the betadine disclosing the clear flow from the eye, suggesting an aqueous leak for which meticulous wound surgery was done immediately. and all traces of betadine was flushed out to prevent any secondary inflammation, corneal changes, or any discomfort to the patient or to the patient's eye. So the results are, out of the 150 cases that we saw, 110 patients underwent a small incision cataract surgery, 35 underwent corneal tear repair, and 5 underwent trabeculectomy. 66 patients had positive SEEPS test, out of which 60 patients had usually a post-operative wound leak following a small incision cataract surgery, 4 were a post-corneal tear repair surgery which had a SEEPS positive test, and 2 patients were after a overfiltering bleb following a post-trap case. And premature entry was the most common cause, comprising of around 45 cases or 75% of the cases, followed by floppy iris syndrome, which comprises of around 25% of the cases. And then there was a significant reduction in the number of resurgeries that we did after starting this test, where it was around 12 in the previous year, which dropped down to around 3 to the corresponding next year. Discussion. Study by Valenti et al. Found that wound leaks have 44 times more frequency of developing endophthalmitis due to contamination of the wound. And study by GSP found that in 100 cases, almost 1/3 of the incisions leaked. This was a study he did in phacoemulsification cases. And if the fluid is coming out at some point, most likely after a blink, the eye wound sucks in the fluid from the eye surface, leading to intraocular contamination. And one more study by Sletedal J.K. et al. Reported a case of iris prolapse through a clear corneal incision 2 weeks after a phacoemulsification case due to post-operative vomiting. To our knowledge, there is no study which helps us to identify leaks in procedures which have scleral incision like small incision cataract surgery. And especially among postgraduates, this can come in handy where a quick and efficient method can be done to identify the leak, and immediate post-operative suturing can be done on the same intraoperatively to prevent any leak. So concluding, cataract surgery is the most commonly performed surgery in the world, giving sight to millions. The need of providing maximum asepsis has led to development of guidelines and stringent aseptic precautions. So identifying this leak is of prime importance, which can help us reduce further complications. Especially in camp OTs, this can be handy where you can immediately intraoperatively find out if there is any leak. And the additional benefit of using betadine is that it also sterilizes the surface of the eye at the end of the surgical procedure. Therefore, SEEPS test plays an important role in identifying any post-operative wound leaks for which immediate treatment can be taken. My references for this. Thank you.
Thank you,
Hello.
doctor.
Yeah.
Questions, please.
Thank you. Nice presentation. Who were the surgeons? Were they post-graduation, the students?
All the
All of
postgraduates, ma'am, who were learning intraocular surgeries. So it was done in them.
Second year, third year?
It was first year, second, all 3 years.
All 3
Yes,
years.
ma'am.
So are you doing the SEEP test in all the cases post-operatively?
Sir,
Are you doing the SEEP test in all the cases post-operatively in a small incision?
if we suspect there is a premature entry, then we do a SEEPS test, sir.
And other ways to detect it
And
without?
other tests can be can use a fluorescent stain. They are fluorescent strips, sir. But the additional thing is that you have to do it post-operatively on post-op day 1, and then again take back the patient for research.
On the table. On the table. If we put the air in the antechamber and try to push it from the opposite side, we can easily detect it.
Right, sir.
And when we perform the surgery, we are able to diagnose whether leak is there or not. It depends on how the tunnel is made by the surgeon.
Okay, sir.
Fine.
Thank you, sir.
Thank you. Should I invite next?
May I now call upon Chief and Presenting Author Dr. Kriti Bhatt to present her paper on prevalence of dry eye, categorization and pathological correlation, a tertiary case study.
She is a non-ratified member, so you will not be considered for the award. Okay.
A very good morning to all. I am here to present my paper on prevalence of dry eye, its categorization according to DEUCE 2, and pathological correlation, a tertiary care hospital-based study. Dry eye is a major healthcare problem and one of the most frequent cause of visit to an ophthalmologist. DEUCE 2 in 2017 defined dry eye as a multifactorial disease of ocular surface characterized by loss of homeostasis of tear film and accompanied by ocular symptom in which tear film instability and hyperosmolarity, ocular surface inflammation and damage, and neurosensory abnormality play an etiological role. The aim of my study was to find the prevalence of dry eye in a tertiary care hospital with the objective of to diagnose and classify dry eye according to DUCE 2 classification into aqueous deficient dry eye, evaporative dry eye, and mixed variety, and to determine the associated risk factors and look for grade of squamous metaplasia in each group. This was a cross-sectional hospital-based study carried out over a span of 1 year. We included patients more than 30 years of age who were selected via systematic random sampling, and we excluded patients having any active ocular surface infection, history of any contact lens wear, dryness of mouth or enlarged glands, history of any intraocular or extraocular surgeries within past 12 months, or use of any topical eye medications. The subjects were given dry eye questionnaire 5, and patients having dry eye questionnaire 5 score of more than 6 underwent fluorescein breakup time and ocular surface staining using Van Bistedville score, and any patient having dry eye questionnaire 5 score of more than or equal to 6 and at least one positive objective test were labeled as dry eye disease patient, and they were further subcategorized into aqueous deficiency, evaporative, and mixed variety based on tear meniscus height and slit lamp examination, and those who gave consent were further evaluated with impression cytology. A total of 897 patients were screened in our study, of which 485 were males and 412 were females. And the prevalence of dry eye from our study was found to be 29.54%, of which aqueous deficiency was seen in 37.4%, evaporative in 37%, and mixed in 25.7%. This pie diagram and bar diagram depicts that the prevalence of dry eye was found to be more common in elderly, more than 60 years, followed by third decade, fifth decade, and fourth decade. It was found more prevalent among females and urban dwellers, and diabetes, psychiatric illness, thyroid, smoking, and history of previous cataract surgeries more than 12 years and use of visual display terminal devices were found as significant associated risk factors. The impression cytology in different subtypes of the dry eye showed a reduction in goblet cells, and a marked reduction was seen in mixed variety of dry eye. And this slide depicts the grading. We found different grades of squamous metaplasia among dry eye patients, and the mixed variety showed a higher grade of squamous metaplasia compared to other subtypes. Dry eye, being a major healthcare problem, is overlooked and underdiagnosed due to lack of standard dry eye diagnostic criteria. Our study thus used the most recent diagnostic criteria as proposed by DUCE 2 for diagnosing and categorization of dry eye patients, and the prevalence in India ranges from 18.4 to 54.3%. And the prevalence of dry eye found in our study was 29.54, which fall in the above range. We found majority of patients in the age group of more than 60 years, decreased tear secretions, increased meibomian gland dysfunction, and thinning of the lipid layer with advancing age may be a probable explanation. The dry eye was also found to be more prevalent among females, which could be due to hormonal changes, and more prevalent among urban dwellers. This could be explained due to increased uses of visual display terminal devices, air conditions, and presence of air pollution in the urban population. Major limitation of our study was that it was a hospital-based study, so the study may not represent the real picture at community level. Secondly, it was a cross-sectional design, so it restricts our ability to infer into the causality, and all cases of gross corneal conjunctival pathologies, contact lens users, use of topical medications, systemic conditions were excluded from our study, thereby underestimating the dry eye prevalence. Fourthly, the impression cytology could not be performed in all dry eye subjects. Thus, to conclude, the hospital-based prevalence of dry eye was found to be 29.5%. Thus, our study reflects a major burden of dry eye on routine outpatients. And our study also showed that age, sex, residency, and occupation have a significant impact in the development of dry eye. And reduction of goblet cells and different grades of squamous metaplasia were observed among dry eye patients. Mixed groups showed a marked reduction of goblet cell and a higher grade of squamous metaplasia. These are my references. Thank you.
Thank you, Doctor. Good study. Any question from the guys?
Thank you.
Our next presentation by Dr. Reshma Ranade. artificial intelligence use application or simplified guidelines for keratoconus.
Good morning, everyone. I'm here to talk on a novel AI-based application for simplified guidelines for keratoconus management. At the onset, none of the authors have any financial interest in the subject matter of this study. Just a minute. Okay, so let's begin with why keratoconus is a problem. So the global prevalence and incidence of keratoconus is about 0.2 and 1.5%, but in our own tertiary center, we have seen a prevalence of about 5.2%. But are we seeing the true picture here? So there are recent studies which show the incidence of subclinical keratoconus in children who have been diagnosed with refractive errors, which goes to say that we are probably scratching only the surface of the problem. Our healthcare system primarily consists of the primary healthcare centers, the community, and the medical colleges and the hospitals, with a staffing model which comprises of the nurses, optometrists, residents, fellows, junior and senior consultants, and the heads. But are we all diagnosing at the right time and giving timely treatment to our patients? So across the staffing model, we have the same questions that we come across as to which patient will progress and who will not, when to cross-link, and how can we decide upon the treatment plan. Another question is, are we reaching the unreached? So this brings us to our research questions. The first being, can we effectively identify who will progress and who will not? To answer this, I would like to draw your attention to artificial intelligence. Artificial intelligence and machine learning are computer-based tools which help you to look at parameters which are other than the obvious ones. So we used the random forest classifier, which is a machine-based algorithm, in order which picks up certain parameters and accurately predicts which particular parameter would help you to identify which case will progress and which will not. This is a recent publication from the JRS, and we used a total of 413 patients who were then classified as stable and progressors, and we developed 3 target groups based upon the change in the Kmax between 2 visits. So between model A, B, and C, we found that all the 3 models had similar accuracy, though model C was the most accurate in picking up stable versus progressors. Coming to the next question, can we choose an appropriate treatment for those who progress? So we incorporated our published and validated 5-point nomogram along with the high-risk characteristics for the progression of keratoconus to develop an AI-based application. Now, could we convert this into a smartphone app to predict the progressors accurately and suggest management? After an ethics committee approval, we exported 2,500 scans of 200 eyes of patients who had keratoconus from the Pentacam, and we classified them as stable and progressors based upon the Kmax. Keratometry, KC indices, and Zernike wavefront aberrations were given as features to the AI for training, and progression and management-derived data was used to build a smartphone-based application. Machine learning was utilized to teach the AI the treatment algorithm based upon our published 5-point nomogram. So coming to the workflow of the KC app, so after entering the risk factors and the demographic data, you export the imaging data using the USB, and after the high-risk characteristics are selected, it gives you a scoring based upon the ABCD, and it classifies them as stable or progressors, and then suggests an appropriate treatment. Now the treatment which it suggests can be either a laser-based treatment followed by a cross-linking, or it can even be a manual cross-linking alone, or even for the advanced keratoconus, it may suggest you a keratoplasty. Coming to the results, the random forest classifier-based AI model predicted the disease progression with an area under the curve as 0.92, and sensitivity and specificity was 80 and 87%. And of the KC app, in successfully identifying the progressors and suggesting the treatment was about 96%. Now, we aim at creating an integrated health system with the KC app, so we are not only primarily targeting the medical colleges or the tertiary care centers, but we aim to make this app applicable for the municipal hospitals or the healthcare centers, or wherever the outreach programs and wherever the children can be picked up, particularly with those who are having a subclinical KC. Many studies have predominantly looked at Kmax change, and they do not look at the other changes on the other Pentacam tomographic parameters. This is the first AI-based smartphone application to predict the progression and choose the right treatment. So we have known that there are various classification systems and management algorithms for the keratoconus, but this is the first study to integrate AI and improves the predictability for progression and management. The KC app would be a one-stop solution, particularly helpful in reaching the masses, where basic tomographic facilities are available to cater treatments and to monitor progression. To conclude, The KC app can function as a useful tool in practice, not only at the tertiary healthcare centers, but also at the level of community healthcare centers where basic facilities for tomography can be made available. Thank you.
Any questions from the panel? It was excellent presentation, excellent study.
So very good one. I just want to know, like, what level in community are you expecting to that this kind of model can be used by ASHA worker or something, or some other group of workers who can use this AI at community level?
So, sir, those children particularly, say they have a high cylinder, those who need an imaging tool or who would need a referral. So if they are referred to a place where the imaging would be available, now I'm not talking about the Pentacam alone here, it could mean any topographer from where we can get an imaging. In that case, once the imaging is obtained, along with the high risk characteristics, this would help you to identify whether the child would progress or not and what treatment would be required at that stage. So probably not a primary healthcare center at this point in time, but we are a developing country and we are trying to make things available at every level. So
thank you. Good.
Thank you.
Very nice.
Thank you.
Yes, yes.
I think it would be very difficult for a placebo-based topographer. So most of the people will have topographers which are, placebo-based, and they don't have shunt plug imaging. So it will be very difficult to get the data and have the AI used in that. Children do not cooperate. I have a predominantly pediatric ophthalmic practice. They do not cooperate with shunt plug is one thing. They don't even cooperate for placebo-based topographers. So higher cylinders, yes, there is a risk, but it is very difficult to quantify when it comes to children. Thank you.
So, sir, I agree to what you're saying, that children, say under 6 years or 10 years also, they are not very cooperative. But at least beyond that particular point, we can pick them up early. Another thing is, as you said, that the Scheimpflug based tools do have so many parameters, but primarily gold, as a gold standard for picking up progressors, the studies have always have looked at Kmax as such. But there are other parameters which the Pentacam gives you as well. It gives you the BAD-D, it gives you many other indices, which is the vertical asymmetry, it gives you the horizontal asymmetry. So all these parameters, when the human mind may probably not be able to compile all this and identify whether the child or the patient would progress or it would remain stable. So the AI tool particularly was developed so that all these parameters can be taken into account. Yes, sir, they do. But just as we say that the clinical impression is one thing and the machine...
there is some time constraint, so we'll stop the discussion over here. You can discuss outside the hall. And thank you very much.
Thank you, ma'am.
Let's now move to the next paper, ocular complications following anti-VEGF injection for ROP. The presenter is Dr. Swikruti Jena.
Good morning, everyone. I'll be presenting on the topic ocular complications following anti-VEGF injection for ROP. Introduction. In developing countries like India, there has been a rise in incidence of ROP in the recent years, which corresponds to the establishment of intensive neonatal regimens in premature babies who would have not survived previously. ICROP recommends screening of infants less than 1750 grams or gestational age of less than 34 weeks, as well as at-risk infants outside this criteria. The dysregulated angiogenesis in ROP actually happens in two well-defined phases. In phase 1, there is relative hyperoxia, which results in oxygen-induced arrest of normal vascular development with obliteration of immature retinal vascular elements. In phase 2, the retina becomes more mature and metabolically active, which results in relative retinal ischemia that drives the pathological vasoproliferation. Anti-VEGF injection is important for the treatment of ROP. Off-label use of bevacizumab is an effective treatment for type 1 ROP and more effective than laser in zone 1 plus ROP. However, late recurrence was found in some studies, therefore long-term follow-up is required. Initially, the cryo-ROP study defined the treatment guidelines, which was later modified by the ET-ROP study. And according to that, type 1 ROP is zone 1, any stage ROP with plus disease, zone 1 stage 3 ROP without plus, or zone 2 stage 2 or 3 with plus disease. And type 1 ROP is the one which currently requires early intervention with either laser or intravitreal anti-VEGF. Now, the aim of the study is to determine the ocular complications following anti-VEGF injection. Materials and methods, an ambispective observational study was done in tertiary care center from June 2019 to May 2020. This included 232 eyes of 116 preterm infants of type 1 ROP who have received anti-VEGF injection. These infants were followed up for 1 to 2 years till July 2021 and the complications were documented. Intravitreal injection of bevacizumab, that is 0.625 milligram in 0.025 ml was given in OT and also in SNCU. The follow-up was done weekly for 1 month, 2 weekly for 3 months, and then monthly for a year. Now the results, a total number of babies are 116 babies, that is 232 eyes. The males were 64 males and 52 females were taken. The mean gestational age and birth weight was 30 plus or 2 weeks, and the weight was 900 to 1650 grams. At presentation, we found 39 babies with zone 1 without plus disease, 62 babies with zone 1 with plus disease, and 15 babies with zone 2 stage 3 with plus disease. Now the treatment in form of anti-VEGF injection was given. Full maturation was seen in 118 eyes, that is 51%. Vascular arrest alone was seen in 59 eyes, that is 25%. Vascular arrest with tortuosity in 43 eyes, and reactivation of disease was seen in 12 eyes. Now 55 eyes received subsequent additional treatment in the form of second dose of anti-VEGF, that is 23%. And on subsequent follow-up, we observed progression of ROP in 12 eyes of 6 babies, that is 5%, which required an additional laser treatment. And the complication included progression of retinopathy in 12 eyes, vitreous hemorrhage in 3 eyes, and endophthalmitis in 1 eye, and cataract also in 1 eye. These are the pictures of endophthalmitis and cataract in babies. Now, as we can see, full maturation was, we had followed up at 1 week, 4 week, and 12 weeks. Full maturation was seen in 118 eyes at 12 weeks, vascular arrest alone in 59 eyes, and vascular arrest with tortuosity in 43 eyes at 12 weeks, and reactivation was seen in 12 eyes. Now here's a bar chart showing the same. Now discussion, 232 eyes of 116 preterm infants of type 1 ROP received anti-VEGF injection. The mean gestational age was 30 plus or minus 2 weeks, and weight was 900 to 1650 grams. The most common finding was babies with zone 1 with plus disease, that is 62 babies. Full maturation in 51% babies, vascular arrest alone in 25%, and vascular arrest with tortuosity in 18%, and reactivation was seen in 12 eyes. Now 55 eyes received additional treatment in the form of second dose of anti-VEGF, and on subsequent follow-up we have seen progression of ROP in 12 eyes which received an additional laser treatment, and the complication included progression of retinopathy in 12 eyes, vitreous hemorrhage in 3 eyes, endophthalmitis in 1 eye, and cataract in 1 eye. Now recurrence of ROP was seen in 5% which required additional laser. Now reoccurrence of the disease is known by vascular arrest with tortuosity, extraretinal fibrovascular proliferation, or non-vascularization. Now coming to conclusion, our study demonstrated that anti-VEGF injection is beneficial for type 1 ROP in posterior zones. Recurrence of ROP requiring treatment may be anticipated predominantly during a 15-week period after anti-VEGF monotherapy. Meticulous follow-up is essential after treatment of type 1 ROP till the disease progresses, and special vigilance in the risk period after the treatment can help in detecting ocular complications. Thank you.
Very good, ma'am. Any questions from Dr. Vaishali?
What is ambispective study?
Basically, we have seen up till from June 2019 till May 2020, we have seen the study. That is the retrospective part, and then we have followed up those patients later on for 1 year also to see the like delayed complications of cataract and endophthalmitis.
Okay, good. What made you to keep this paper as part of community or social ophthalmology? Why not into retina or something pediatrics?
ROP is a
Public health problem?
No, not really, but.
Okay, thank you, ma'am.
Thank you.
So we go to the next paper now. The next presenting author is Dr. Nidhi Pandey. Is she here? Okay. Descriptive study of inherited retinal dystrophies, IRD, in a tertiary eye center in central India.
Okay. So, good morning, everyone. So, I'll be talking about the descriptive study of IRDs, which is inherited retinal dystrophies in a tertiary center in India. So, what are basically an IRD? IRD is upcoming issue in our society. It is a group of rare Mendelian neurodegenerative syndromic, non-syndromic retinal disorders caused by a lot of mutations over 200 genes. These genes are basically encoding the proteins of photoreceptors, RP, and retina neurons. So they have a lot of overlapping phenotypic features, different phenotypic features. So the prevalence rate is basically varying from 1 in 750 to 1 in 5,000 depending upon the region and the level of consanguinity. So we face a lot of inheritance spectrum in that, likely from autosomal dominant, autosomal recessive, X-linked, and mitochondrial. So now in the upcoming world, we are having new innovative and non-invasive tools for this genetic testing, which includes single gene DNA sequencing, NGS technique, and whole genome sequencing. So these tools are very crucial for detecting the molecular pathologies of the disease, diagnose unresolved cases, improve the genetic counseling, and develop a new advanced gene therapies to change the paradigm of various IRDs. So the advantage of this study, which we did in our institute in the central India, is that it precisely helped us to identify the relative frequencies which was prevailing in our central India, and it allowed the proband's family and the patient's family for pre-symptomatic diagnosis of the disease even in the younger individuals. So what is the role of ophthalmic genetics here? So basically the ophthalmic genetics, it helps us to introduce various new genetic tests into the daily clinical practices in the tertiary institute, as I'm working in a tertiary institute. So to create a genetic panel in conjunction with exact clinical diagnosis, resulting in informative and accurate diagnosis of the patient, to increase the molecular test sensitivity for reaching a higher mutation or molecular diagnosis, and to open a therapeutically personalized strategy to look upon for curing the disease. A major challenge which exists in the identifying novel gene responsible for the causing disease is to have the studies open to a broader aspect, which we are lacking right now. So our study was a retrospective cross-sectional descriptive study which included 31 cases in span of 2 years from July 2019 to July 2021 in our tertiary center in central India. After taking a proper clearance from the ethical committee, we took the clinical records of 200 patients and reviewed for suspected IRDs. The proper diagnosis of IRD was made after conducting a proper clinical examination and supplementing it with relevant ophthalmic investigations like our anterior segment proper investigation and a posterior segment investigation with a dilated 20D lens. So how we collected the data? So after a proper outpatient and demographic registration of the patient, we had a detailed clinical and a family history taken for all these 31 cases, including the history of consanguinity and the type of inheritance. Variables which we included in our study were sex, ages at the symptom onset, and age at the diagnosis of the patient. Associated systemic feature, any prior ophthalmological visit done by the patient, inheritance pattern, pedigree data, and mutated gene if the patient had it checked somewhere out. So BCVA was calculated according to logMAR chart which we had. Proper anterior segment evaluation was done with the slit lamp, and an IOP was taken up with the applanation tonometer to rule out any other ocular pathologies.
So a detailed posterior segment evaluation was done through an IDO and 20D lens, and it was classified into various inherited retinal dystrophies which we could find out. Proper investigations, ophthalmic investigations which were done, spectral domain OCT of macula was performed, and it classified the patients into preserved, atrophic and edematous. Proper electrodiagnostic tests were done, including ERGs and EOGs. Perimetry was performed. Finally, we classified our patients into the 5 groups according to the WHO low visual scale classification. The groups were no vision, low vision, mild low vision, moderate low vision, severe low vision, and total blindness. So statistical analysis was done, and quantitative variables were calculated, including various frequencies, mean, standard deviation, range of the data through the SPSS version of the program which we had. Now this is the result which we obtained from our institute. Maximum patients were found of retinitis, maximum patients of retinitis pigmentosa were found. The second most common pan-retinal pigmentary retinopathy which was found was Leber's. Among macular dystrophies, Stargardt's was the most common dystrophy which we found in our part of central India. The Best's was the second most common macular dystrophies which we found. The other vitreoretinopathy which were found was hereditary macular degeneration. There were 2 cases which we got of HMD. So coming to the 5 cases of RP which were diagnosed were syndromic, and most common syndrome which we found was Usher syndrome. So the inheritance pattern we could not develop because of the lack of information and genetic testing equipments. This is what I'm talking about, which is lacking in various tertiary centers still in India. So among these 25 patients, 12 patients of total RP sample had at least one family member affected with the disease, where the progression had not set in. So thus this early diagnosis helped them to make a proper livelihood for that patient, for that family member in the future. So maximum among the diagnosed RP where first or second degree of consanguinity was present in their family history of marriages. So coming to IRDs, basically it has classified into 5 pigmentary, macular, stationary, optic nerve, and other vitreoretinopathies. So current study was important for us because it helped us to calculate the relative frequency of various IRDs, specifically the RP which was found in our part of India. The second one, most common, was Stargardt's, coming up with next with Leber's,
Can you
HMD,
conclude,
and
please?
Yes, ma'am. So the key here is I wanted to highlight with my current study the prevailing substantial delays in diagnosing all these genetic diseases and emphasizing the need to perform more genetic study in the current region. So by highlighting our weaknesses, we can lobby the concentration of health services in the center and the state to the various government institutions to improve our low visual aid departments, genetic detection centers, and counseling centers, as these are the tertiary centers of our country. So these are the references which I took in. Thank you, ma'am.
Thank you, doctor. Our last presentation for this session is by our well-known doctor, Dr. Jitendra Jathani. His pioneer work done in the ophthalmology.
So good morning, everybody. There was a landmark paper in 2010 by Brand-Holden Institute in ophthalmology, where they showed that almost 1.9 billion people were myopic in 2010, and this data was extrapolated, and they found that this was projected to have an increase to almost 52% by the end of 2050. So we know, with this background, we also know that there was a wonderful meta-analysis done in 2020, which was published in BMC Ophthalmology, where they suggested that low outdoor activities and near work were one of the significant factors involved in progression of myopia. Now with this background and with lockdown, imminent near work, secondary to COVID-19, which had serious concerns about raised or increased screen time and low outdoor activities, more near work, we did a study to present a review of children who were already myopic, who were already in our clinic, and were myopic, were not on any treatment for myopia, just wearing glasses. These were the children who were regularly followed up for another 6 months, and after that 6 months, one of the eye was chosen to remove any bias which can arise on taking the two selection bias. The pre-lockdown included children who had already had a 1-year follow-up, and they were progressors but did not want to have any treatment. So that was the difficult part, and that is the reason we have a very small sample size, because most of our children who present to us, we try to convince them that since they are already a progressor in myopia, we should have, they should have something to stop their progression. All the children had detailed ophthalmic evaluation, descriptive and inferential statistics were performed. Because it was a non-normal distributed data, there was only 30 patients, we did use median instead of normally we use a mean for this, and we use first and third quartiles and interquartile ranges, which I will be showing. So the mean age was 8.7 years, but mean progression in myopia per year prior to lockdown, when they were progressing normally, was minus 0.75 diopter. This is median with an interquartile range of 0.5 to 0.75, and post lockdown it was 1.25. We also calculated the axial length, and we found that post lockdown the median was 0.63 compared to pre-lockdown, which was 0.24. So correlation with near work is well known. It is well known that that near work, ocular strain, increase in indoor timings, and can cause increase in axial myopia. This was predicted by a wonderful letter to our editor from Narayan Netralaya by Sumita et al. They predicted during the lockdown that there could be a spurt of increase in myopia. They in fact found in their OPD numbers that there was significant rise in refractive errors. A similar increase was also noticed in school screening examination, which was done in China. The problem was that it was unclear in their study whether they used the same set of studies or they just did two set of studies and had a screening protocol for children. There was another study which was a good study by Chang et al., which was more comprehensive, where they divided the study into 4 rounds with 3 periods depending on the lockdown policies, whether there was a complete lockdown or not. The study had a very large sample size, but again it was more of a screening study. They did not do a cycloplegic refraction, nor did they do a biometry, but it was a population-based study, so that was a good part of that particular study. The strength of our study is that it was done on the same set of children who were reassessed at multiple intervals. So we knew these same children pre-lockdown and post-lockdown. Hence we could show that lockdown was one of the important factors for the increase in myopia and axial length. The reason for this myopia and this increase in myopia could be implicated directly to the increased indoor time and near work, which is already a known risk factor. The limitations, obviously, the number was small. It was a retrospective in nature. And obviously a better, larger sample size at this point, since lockdown was unpredictable, it was unplanned. We believe that these children can be followed up further, and we can see whether the myopia progression reduced in them or not post lockdown. So we can easily conclude from our study that myopic progression was significant during quarantine period, and therefore it calls for strategies to prevent this. So this is a wonderful insight we got, that quarantine or near work or indoor timings do increase the progression of myopia. And since Dr. Praveen is here, I would like to say that we should include this in National Myopia Prevention Program with Orbis and Vision 2020 already looking for childhood blindness. That's a chief area of interest. It would help in creating awareness and detecting these children early, and would help in formulating policies to prevent myopic progression further. Thank you so much. Thank you for the time.
You have seen mainly it's a near work correlation.
Near work indoor timings because of the lockdown, yes sir.
And it may be something other way around, that children, they have not gone outdoor.
Yes.
That may be one of the factors.
So these are 2 factors, near work, indoor timings. We saw the 2 things only.
Thank you.
They did not get free air, oxygen.
Thank you, Dr. Jitendra.
Thank you, sir.
We will wind up this session now.
Yeah, it was an excellent session, excellent papers. I congratulate all the speakers and all the presenters, and I thank all the panelists and judges over here.
Thank you.
Thank you. Thank you very much.
Can you have a group photo of Khade honke? Can you switch off the screen behind? Or you are? I guess it.
Thank you.
Thank you.
Thank you, ma'am. Thank you, sir.
Thank you, sir.